Hi, I'm Heather McKnight. I work at UC Davis. I'm the Chief of Pediatric Hospital Medicine.
And I'm Leah Tzimenatos. I'm the Chief of Pediatric Emergency Medicine, and I'll be presenting along with Dr. McKnight today. Thank you all for joining us. Neither Dr. McKnight or I have any financial disclosures, but we do just remind you again that the session is being recorded. So by continuing in the session, you're providing your consent to be part of that recording.
We wanted to go over just the general goals. So PACES is an effort to increase evidence-based pediatric care in our community. Our goal is today will be to review evidence-based bronchiolitis clinical guidelines. We'll also talk through the parameters for initiating high-flow nasal cannula in this population, as well as thinking about transfer. And then finally, we'll discuss some of the new RSV prevention strategies.
This is the title of a study back or a review article back in 2013, and it remains one of my favorite quotes about bronchiolitis. I feel like if I was going to present all of bronchiolitis in one slide, this is basically what it would say. Basically, viral bronchiolitis in children, a common condition with few therapeutic options. We'll obviously be getting into some more subtleties and nuances of it, but I think that a lot of what we talk about comes back to how common it is and how challenging it is for us to treat.
To get started, we wanted to just kind of review some of the basics of what happens in bronchiolitis and what's its impact in our pediatric population. So bronchiolitis is a lower viral respiratory tract infection in children less than 2 years of age. In terms of the pathology, it results in acute inflammation, edema, and necrosis of epithelial cells lining the small airways. So all that mucus that we end up seeing. And then also it can cause bronchospasm or wheezing. The reason that it's so important is it's the number one reason for admission to the hospital for infants less than a year. And that's been true throughout our career. And will be interesting to see if that continues. But so far, again, is one of the leading diagnoses. And so if we find out strategies to decrease this can have a really big impact on our pediatric population in terms of hospitalizations and also seeking acute care. Generally, it's self-limited and has a good prognosis.
I think over time, the terms RSV and bronchiolitis have become kind of synonymous. And we know that in terms of viral causes of bronchiolitis, RSV is definitely one of the leading causes. Most studies show it up at about 80% of cases related to RSV, but we know that other viruses can cause bronchiolitis as well. So rhinoviruses, more recently, we've seen it related to COVID. We know it can be related to influenza, human metapneumovirus. The non-novel coronaviruses can cause bronchiolitis, as well as, although paraflu is known for causing croup, in certain populations, we can also see it causing bronchiolitis as well. The other thing that's interesting about clinical bronchiolitis is that often it is related to co-infection with multiple viruses. I think most notably over the past couple of years, we've been seeing co-infection with RSV and COVID, causing a particularly severe phenotype of the disease. But any of the viruses can really combine with others to cause bronchiolitis. Looking more specifically at the RSV causes of bronchiolitis, we know that as many as 20% of all infants can be affected. So as Dr. McKnight was saying, this is really sort of a major public health issue in pediatrics and probably one of the bigger ones that we face. And it's also a little bit tricky because it tends to be longer duration of infection and longer duration of symptoms than some of the other causes, some of the other viral causes. So a median duration of illness of 12 days is longer than I think most families are used to dealing with viral illnesses. And so it creates, I think, more concern as well as more inconvenience and challenges for the families. Besides kind of that duration of illness of 12 days, the cough can continue all the way up to 4 weeks. It should be gradually improving over that period of time, but that can be hard to explain to families who have been listening to their infant cough for an entire month. And then another interesting fact about RSV that I think many of us are very familiar with is sort of the seasonality of it. It tends to peak most often in the winter, so classically between December and March. Especially pre-COVID times, we know that it was quite predictable and when we would expect to see children with bronchiolitis and RSV infection. But interestingly, it seems that the pandemic really sort of disrupted and shifted those seasonal peaks. There's some interesting data that was collected, and it's been true nationally and internationally. But this is some more local data from the California Department of Public Health showing what RSV infection has looked like over the past several years. So just to orient you to the slide, the y-axis is the percentage of positive specimens for RSV, and then the x-axis is week in time, with sort of starting in October and going through September. So you can imagine that January is kind of a third of the way over on that horizontal axis, and you can see that. For those first couple of years, so it's a little bit harder to see the colors, but for 2018 through 2020, we had peaks basically when we would expect them in that sort of January through March timeframe. There is a blue line, a light blue line along the bottom that shows what happened post-COVID in 2020 to 2021, which was basically that we saw almost no RSV at all, certainly none during the winter months. And I think that was a result of the social distancing and masking and closing of so many sort of public spaces that it just was not transmitted and we weren't seeing it. And then interestingly, we actually started to see it in sort of July and August of 2021, and then had a really early peak in October to November of 2021, which is sort of a really different time. And then it also sort of lasted a long time, sort of all the way into the spring and early summer, which was pretty unheard of for us as well. The next year is that sort of second peak that you can see there that seems to have shifted back over, and that was the one that we sort of think of as our triple-demic last year, when it was associated also with the co-infections with COVID and with influenza sort of all hitting at the same time. And then in that bold blue, you can see what's just starting to happen this year. So at least in terms of our timing, it looks like we're pretty similar this year compared to last year. I think we're all hopeful that the peak will not be as high, and that hopefully we won't correspond exactly with peaks of influenza and COVID like we did before.
So we wanted to talk a little bit more about the clinical course. As I mentioned, RSV and bronchiolitis tend to be high morbidity, but low mortality. This data was pre-pandemic, and pre-pandemic, about 2 to 3% of affected infants were hospitalized. If you look at various studies, anywhere from 19 to 65% admission rate if these patients presented to an ER and a tertiary care pediatric hospital. And then of those hospitalized patients, 3 to 7% were classified as having respiratory failure, and there was a less than 1% mortality. I think one of the other things in terms of kind of thinking through how it affects our pediatric population, 2/3 of children will get RSV by 1 year of age. So again, a lot of kids who are getting this viral illness, and then along the spectrum having a different impact in terms of the severity of their illness.
And we know that there are certain risk factors that will put children at higher risk for developing severe disease, including the sort of respiratory failure and need for hospitalization that we were just talking about. Probably one of the bigger players in that is prematurity and chronic lung disease associated with prematurity. But even for our term infants, just being younger at the time that bronchiolitis season hits puts them at increased risk for severe disease and complications. We also know that children with underlying anatomic lung disease, with neuromuscular diseases, or with hemodynamically significant congenital heart or cardiac disease are at increased risk. Being exposed at home to tobacco smoke can make it harder for infants to clear secretions and to clear respiratory viruses, so they're also at higher risk for severe disease, as well as infants who have who have a family history, so maternal history of asthma, are at increased risk as well. In the past, for some of our higher risk infants, we have had basically one option for prevention, trying to reduce the risk of contracting RSV at all and developing severe disease if they do. And that is palivizumab. I knew I was going to get it wrong. Palivizumab, or Synagis, which has been FDA approved since 1998 for for preventing RSV. It has been available for children who are less than 2 years old, who have certain conditions, basically those risk factors that we talked about for severe disease. It's a little bit cumbersome in that it has had to be administered once a month during RSV season, but it has had efficacy in preventing both RSV infection as well as hospitalization due to RSV in these high-risk infants. And again, previously, this was the only option that we had for infants who were high risk. It was exciting to see some of the news coming out in this past year about new options for prevention. So the main one here is nirsevimab with the brand name Beyfortus, which is another monoclonal antibody which is available for prevention of RSV. It's been shown also to be effective in reducing risk of infection. It shows about a 70 to 80% relative risk reduction for infants getting infected with RSV, and then about a 60% relative risk reduction in hospitalization for RSV. It has a similar safety profile to Synagis, but I think what's nice about it is that it has a bigger target population. So rather than just being children who have underlying health conditions that put them at risk, it also includes infants who are in a young age at the time of RSV season. And so basically any children who are less than 8 months at the time that they're entering their first RSV season, they are eligible for administration of Beyfortus and hopeful prevention. The other nice thing about it is that it's administered as a single intramuscular dose, so it's a longer acting monoclonal antibody. So they just need one dose for the entire RSV season rather than the monthly doses. The dose varies depending on the infant's age with a cutoff at 8 months, as well as their weight with a cutoff at 5 kilos. So depending on their combination of age and weight, they'll get anywhere between 50 and 200 milligrams. It can be administered in pediatricians' offices, and there's no contraindication to giving it at the same time that other routine immunizations are provided. And it also can be given at birth before the children, newborns, leave the hospital as well. So lots of options for when we can administer it to help prevent this disease.
And as this has come out, one of the other challenges has been that there is a shortage of the 100 milligram dose. And so I just also wanted to go through what the CDC has recommended in terms of strategizing to best serve our population with the supply that we have. So there's no changes for our kids who are less than 5 kilos who will be getting the 50 milligram dose and our most vulnerable population. But for infants who are greater than or equal to 5 kilograms, they've asked that people prioritize infants that are less than 6 months, our American Indian and Alaska Native infants that are aged less than 8 months because they have a higher risk of increased morbidity and mortality. And then also infants who are 6 to 8 months with high risk conditions for the same reasons. And then finally, for children who are 8 to 19 months, they recommend that we stick with Synagis for that population instead, given the limitations of our current supply. One other thing that I just wanted to mention is that the advice has also been not to give 2 doses of the 50 milligram to get to 100 for that older population, but again, to preserve those 50 milligram doses for our youngest patients. In terms of other prevention, the other exciting news is that they've come out with a vaccination for birthing parents. And so Abrezvo has been released and it's given to pregnant people who are 32 to 36 weeks of pregnancy. At first, when I looked at this, I was a little bit confused because that seemed on the earlier side of gestational age. If you want to get a little more specific and think like an OB-GYN, it's up to 36 and 6/7 weeks. And so up until somebody gets to 37 weeks of pregnancy, they're eligible for the vaccine. This is given to babies who are born to mothers who get RSV. And the goal is to get them this vaccination 2 weeks before delivery, which is why the timing is what it is. And so that passive immunity has a chance to occur and for the baby to get those immunoglobulins. The other population that they've also come out with an RSV immunization for is our older population. That immunization is our RXV is what I'm going to say. We'll see if I say that right in the future once I really learn how to say it right. But that's for adults 60 years and older. I looked through that data just to see. I don't think we have any clear information yet in terms of the impact of spread to our younger patients. But the biggest reason for that population is to prevent morbidity and mortality because they're also a very high risk population. But also we'll be curious to see if it also decreases passing it along in the community.
It's interesting with the shortage of the 100 milligram dose, I've been hearing more efforts to get mothers immunized or pregnant parents immunized because if the parent has received the immunization at least 2 weeks before delivery, then we actually don't need to administer the monoclonal antibody, regardless of even if the infants are at young age at RSV season. It's a little bit tricky though, because I feel like the pediatricians' offices that are administering the monoclonal antibody are not necessarily the same as the OB offices that are administering the immunization. So hopefully people are getting the news in general so we can focus on those, the preventive options that we do have in this time of shortage.
And then I think one of the other big questions is like, what is the impact of these preventative strategies? And so from a hospitalist perspective, it reduces hospitalization by about 68%. It reduces visits for RSV in the acute care setting by 57% by 3 months after birth. And then if you look even kind of a longer trajectory, for 6 months after birth, it reduced hospitalizations by 57%, and then also reduced visits by 51%. That was in the trials. And so it'll be interesting to see as we begin to give it to our general population, what that data shows. And then ultimately, I think the other important fact is that it reduced the risk of severe RSV by 82% within 3 months and 69% in 6 months. And so that's looking at the population that was requiring high flow nasal cannula, admission to an ICU, or just having severe symptoms of the RSV.
Interesting. I was hopeful that we would see some sort of tangible changes this RSV season. I feel like with availability and uptake, it might be next season before we're starting to feel a difference clinically, but it's still early, so hopefully we will.
So given all these limitations, what can we do? As we've mentioned, we don't really have, in terms of pharmacotherapy, the best interventions, and we've tried a lot of different things, but have not found other things that work. And so the mainstays of our treatment for this patient population, once they have RSV, is nasal suctioning, oxygen if needed, and respiratory support, and then hydration or nutritional support. So as we had alluded to, there's a lot of things that in the bronchiolitis recommendations by the AAP that we're asked not to do. So they state that the diagnosis should be made clinically. Bronchodilators, so albuterol or epinephrine are not recommended. Corticosteroids are not recommended. Antibiotics are not recommended. CPT is not recommended, or chest physiotherapy. And then hypertonic saline should not be used in the ER setting. There's a couple different studies in terms of looking at hypertonic saline in the inpatient setting, and they conflict with one another. So there's no clear evidence that it has a lot of benefit even in the inpatient setting, but does tend to be used a little bit more in that setting. So this is one of the hardest things, I think, to being in the medical setting, is that we are there because we want to help people and do something to make them better. And a lot of times we're used to having a lot of tools in our box to be able to give a patient antibiotics or do something that's going to change the course of their disease. But really, instead of doing something, we have to just stand there. And so we all have probably heard the phrase, don't just stand there, do something. But in this case, we actually have to move forward from that. And instead, don't just do something, stand there. And so I think that's one of the hardest things, is that we really want to try the things that we have at our disposal, even though a lot of times we know they don't have benefit, and some of them actually have some negative side effects.
I think for me, it's been a shift of trying to think about the supportive care that we offer as doing something, when, knowing that the medications and other specific interventions are not going to make a difference. So we mentioned that the AAP guidelines, and they were released originally in 2006 and then again revised minorly and reviewed and released again in 2014. And they do say that bronchiolitis should be diagnosed by history and physical. So they're saying that routine blood testing and x-rays are not recommended for patients who are presenting with symptoms of bronchiolitis. They specifically mention routine chest x-ray is not recommended. That's not to say that there's not a place for it. And in general, we think of it for patients who are experiencing severe disease, so infants who require ICU admission, or if there's a specific concern for an airway complication or for a pneumothorax. And for me personally, I tend to obtain chest x-rays in children who are critically ill, and then in those who have a persistently asymmetric lung exam. We know that bronchiolitis is really a dynamic process. And so the exam can change from moment to moment, certainly from examiner to examiner and hour to hour. And so I'm not surprised if I hear some asymmetry on lung exam, but in terms of reassessing if the asymmetry persists in the same place, that's a child that I would consider getting a chest x-ray in. Part of, I think, what's tricky about making that clinical diagnosis is we do want to think about other etiologies for the symptoms that we're seeing. The differential diagnosis for bronchiolitis I list here, and I think that there is definitely some clinical overlap in the presentations that these kids present with. Um, Early asthma, and I think that's part of the reason that we think about albuterol in this population as well, is something that we definitely consider, and I consider it more in kids as they're getting to the older end of the bronchiolitis age range, and certainly in kids who have recurrent wheezing. Family history and then a personal history of eczema or atopy makes me think of that as well. Pneumonia is part of the reason that those persistent asymmetric lung exams get chest x-rays in my book. But that can be a really difficult one to differentiate in this young age group, especially because chest x-rays can be abnormal from bronchiolitis, just the viral process by itself. Between mucus plugging and atelectasis, you can see some asymmetry, things that potentially look like consolidation. I think that there is potential for overtreatment with antibiotics and confusion and need for repeat x-rays. And so I think that's part of the reason that that we want to avoid routine chest x-rays. But again, with pneumonia on the differential, it's something that we definitely still think about. Pertussis for our unimmunized kids who do have that persistent cough, we want to think about. Cystic fibrosis and anatomic abnormalities come up, particularly in children who have recurrent symptoms. And then cystic fibrosis, again, for kids who are having growth difficulties or failure to thrive as well. I think one of the big things on this list is cardiac disease, both undiagnosed congenital heart disease as well as viral myocarditis, because both of those can present with sort of non-specific symptoms that very much look like bronchiolitis. I feel like every bronchiolitis season, there's one or two kids that slips through. Sort of gets diagnosed initially with bronchiolitis, and then as they tend to have more difficulties or more severe disease, we realize that their symptoms are actually due to a cardiac cause. I think, it was this time last year, I had a child with a aortic coarctation that had not been previously diagnosed, who came in right in the middle of bronchiolitis season, and it was clinically very difficult to differentiate her from the multitude of patients with RSV that we were seeing.
Dr. Tzimenatos, kind of what you think were the clues to help differentiate that patient from other patients?
So for her specifically, she did have a murmur that we could only sometimes hear. The murmur actually wasn't transient, but the ability to hear it over her respiratory noises was. So we could hear her systolic murmur, and that was our biggest clue in her. In other kids I've had with underlying cardiac disorders, tachycardia has been a big clue for us. We're used to children being tachycardic when they are febrile or when they're having respiratory distress or increased work of breathing, but having some persistent tachycardia that was otherwise unexplained was another one of our clues. Sometimes we'll feel sort of a liver edge, some hepatic congestion for kids who are having signs of failure or difficulty oxygenating sort of out of proportion to their other symptoms have been some of the other clues that I have seen over the years.
Yeah, I think sometimes it can be challenging in our like less than 2 month olds because they don't necessarily kind of follow the rules. So some of those kids can have bronchiolitis and they may not have a lot of viral associated symptoms. Sometimes those kids' primary symptoms can be apnea and poor feeding. But I think as patients start to get older, and even in that younger one, it always makes me think twice if they aren't having any of those associated viral symptoms as well. So if they're not having fever, congestion, or some of the other things that we would expect to see.
Yeah, I absolutely agree. And similar to that, for kids at risk for foreign body, it's the same. I think that if we're seeing children who are, especially in that little bit older age range, but if they aren't having the sort of nasal symptoms that I would expect to go along with bronchiolitis, and just having wheezing or lower respiratory symptoms, it makes me think of that as well. So as we mentioned, the guidelines are pretty specific in things that we shouldn't do. So albuterol, racemic epinephrine, although they do mention that we can use racemic epinephrine as a potential rescue agent. So in children with severe disease, I think of these as kids who are not responding to our other modalities, where we're starting to think about whether they would need some invasive respiratory or non-invasive positive pressure ventilation, that we start to think about at least a trial of racemic epinephrine and then systemic corticosteroids as well. And I think that this is really hard. I think that it's hard to not give medications, especially in kids whose symptoms sound very much like other symptoms, right? So the wheezing that we hear with bronchiolitis, when it resembles the wheezing with asthma, like really, it's not going to respond to albuterol. And I think it's probably because of that multiple studies have been done over the years looking for efficacy of albuterol, of racemic epinephrine, and of steroids. There have been some meta-analyses and reviews looking at the combinations of all of these trials. So, roughly 2,000 infants in both the albuterol and racemic epinephrine groups looking for any benefit, and then a randomized controlled trial of steroids versus placebo in 600 infants. And basically none of those, any sort of the combination of those studies did not show any improvement in these infants' oxygen saturations, in their need for hospital admission, or in their length of stay if they were hospitalized. So it's really been well shown that at least for the large group of infants with bronchiolitis, routine treatment with these modalities is not helpful. But what we sort of know theoretically and what's actually done are not always the same, and we know that too. This is administrative data back from 2013, 2014. So again, sort of pre-pandemic, but after the bronchiolitis guidelines had been out for quite a while, looking at what was done to for infants who were less than 2 who presented to emergency departments with bronchiolitis. And basically at that time, they were showing that about 15% of these infants were still getting steroids, about 60% were getting albuterol, and then as high as 30% of infants were prescribed antibiotics. And so I think that it's a little bit hard not to do anything, but I think that this definitely tells us that that there is some room to go, or there has been over time. And I think that seeing patients in the emergency department who have been transferred, who come in from other places, and who are treated by myself and my colleagues, there are oftentimes that we are probably doing more than we need to be. I think what's a little bit hard about it also, though, is that, the studies are for populations of patients, right? And so we're seeing individual patients in front of us, and are there individual patients who would benefit from these modalities? And so I think that thinking really critically about it and sort of deciding that is part of the art of medicine. And while I don't want to overtreat the vast majority of patients, I don't want to miss patients who we potentially could benefit. So I do think there are probably small subsets of our patients who would benefit from these. And just wanted to spend a couple minutes sort of talking about the specifics of when it could be that someone might benefit from one of these. So Dr. McKnight, I'll actually put the question for you: is there a subset of patients that you would prescribe steroids for if you're seeing them in the setting of a bronchiolitis type illness?
So I'll start by saying I almost never give steroids, but the populations where I do think twice about it are patients who have a history of prematurity that was significant and may have some chronic lung disease, who may have been either quite premature or intubated or requiring positive pressure around their neonatal time. Having said that, some of the kids who were older gestations and who really didn't require much respiratory support, I still try not to give them steroids because I find they they tend to have more typical bronchiolitis than chronic lung disease symptoms. And then the other population that I think about it, but again, it's pretty rare that I would give steroids, is patients who have a really strong family history for atopic disease and or even individual history for that particular patient. So do they have a bunch of eczema as an infant or other signs that they are an atopic child? So really, if I'm starting to think they're more on an asthma spectrum, but if I think they're more straightforward bronchiolitis, I try not to give steroids.
Very similar to that. I think especially in children with their first episode of wheezing, it's pretty rare that I would do a trial of steroids. I do think of it as they sort of get up past that upper age limit of our typical bronchiolitis. So, the textbooks will tell us that bronchiolitis is sort of up to the second birthday. And certainly, the virus and the children don't read the textbooks. And so there's sort of a transition period, I think, where we sort of go from that lower respiratory disease to more upper respiratory disease. But if I'm hearing significant wheezing in a child who's kind of at that upper end of 2 to 3, I will think about it. And then kids who present with recurrent episodes of wheezing, especially if someone has given them albuterol along the way and they have responded, then those are kids that I would also think about administering steroids to. In terms of albuterol, it's sort of similar. There's definitely some overlap with that small group that I think about steroids, but this one's probably a little bit broader. So in children who, as you were mentioning, who have a history of atopy, eczema, or a strong family history of asthma, especially if they are in severe distress. So sort of or at least moderate to severe respiratory distress, I will think about it in them. Even if there's a strong family history of asthma, if I'm hearing wheezing in the setting of upper respiratory symptoms and their symptoms are very mild, I still typically don't administer albuterol in that group. But if I feel like, they're going to need hospitalization or some sort of intervention, it's not just responding to suctioning, then I would consider it in that group.
Yeah, and I would say I think the other thing that we've kind of tried to change our mindset around is that if we're giving albuterol, the terminology that we use is an albuterol trial. And so also trying to do some objective assessment pre and post, because we know from studies that our subjective impression and families' subjective impressions of whether it made a difference are not necessarily accurate in whether it actually makes a clinically significant difference. And so the other thing that I really encourage our team to do if we do decide to give a trial of albuterol is to do that objective assessment pre and post.
Absolutely. And then I think sort of along with that, I think not timing it exactly with suctioning the infant, because I feel like, sort of classically, that was what we always did, right? We would suction and give a dose of albuterol and the child would look better. And probably, honestly, most of that was due to the suctioning, but I think we gave some of the credit to the albuterol. So now it's sort of that objective assessment that you were talking about, doing it post suctioning and pre albuterol as well as post albuterol can be helpful. The group that I give antibiotics to is very, very small. This is kids who really I have a high suspicion of a superinfection of some kind. And almost always, I would say that this is an otitis media that's found on exam. The likelihood of bacterial superinfection of the lungs, so a pneumonia, is actually relatively rare. It's not one of the most common complications that we see in bronchiolitis. And maybe because I'm not getting a lot of x-rays in these kids, I'm not seeing those changes in administering it. But the other group that I have sometimes struggled with is children who present with really prolonged symptoms. So beyond what you would expect, even for the length of illness for bronchiolitis, and wondering about whether they meet criteria for bacterial sinusitis. And so that's another group that I will sometimes think about antibiotics. But by then, I'm not thinking of them in my mind as a bronchiolitis. I'm thinking of them as a bronchiolitis plus something else.
Yeah, so I think you had mentioned it earlier, but I do think it's tricky for patients who've gotten an x-ray because a lot of times they'll have atelectasis and it's hard to sometimes distinguish that from a pneumonia. But if the patient's history fits more with bronchiolitis and I'm not seeing any other clear indicators that they seem more ill or have a fever that's persistent past the window that I would expect for their initial viral illness, then I start to think about that. So it's also really rare that I give antibiotics. You mentioned the ear infection. And so I'd say also one other thing that I try to always keep in mind is for our kids who end up hospitalized for a period of time is that if they, again, are having persistent fever or continue to have fever is to look in their ears because some of those kids, even when we look when they initially present, may not have an otitis media, but with all that congestion over a few days may develop one. And so whenever I see a kid who's either having fever longer than I expect or had fever improved and then has a new fever, that's one of the first places that I look.
And then the last one that I added, which isn't really a treatment, but actually part of the evaluation, is viral testing. And I think this is interesting because this has been really a significant shift in practice over time, mainly, I think, in response to the COVID-19 pandemic that we had been pretty careful, I think, before that in our judicious use of viral testing. We know that, as we've talked about, there's not a specific treatment for RSV. So knowing that that's the exact cause of the symptoms had not been an important part, especially in our patients who are not high risk. So we would make the clinical diagnosis. I feel like we would explain to families that it, could be RSV, it could be one of the other viruses, and just explain supportive care. But now I think in the setting of people having home viral testing, common testing in clinics and emergency departments, and sort of that ability to have an answer for what's causing symptoms has really sort of changed the landscape of both, I think, the patients and their families and how they approach viral testing, as well as our clinicians. So I would say, whereas we got it in a minority of patients pandemic, post-pandemic, I think the vast majority of our patients get some form of viral testing. Sometimes we'll just do flu and COVID testing, but often we will add on RSV testing in the younger patients, in patients who are higher risk, and then honestly in patients whose families seem particularly worried, or there's really sort of the slightest reason that it would help to know that RSV is the cause for their symptoms. We'll test for that as well.
Next, I wanted to talk a little bit more about what the tools are that we're using at UC Davis. And so this is our respiratory assessment classification. We developed this tool looking at some of the resources that we already had, as well as resources that other children's hospitals are using. And so how can we, again, objectively assess and provide some consistency between providers, as well as also kind of document a way that a patient clinically changes throughout the course. And so you can see that our first component is the respiratory rate, and that's divided by age, less than or equal to 3 months, 4 to 12 months, and then greater than 12 months. And you can see that their classification, they fall into mild, moderate, or severe. So for our less than or equal to 3-month-old, mild is less than or equal to a respiratory rate of 60, moderate is 61 to 69, and then severe is a respiratory rate of greater than or equal to 70. The next component of our assessment is their work of breathing. This one is a little bit more open to some interpretation, and we had a lot of discussion during developing this of what language to include. But for mild, they either have normal or mild retractions. So I usually think of a kid like this as maybe having some mild subcostal retractions. For moderate retractions, so I start to think about this more for kids who have subcostal, the depth of their retractions, as well as maybe suprasternal. And then if they have mild intercostal retractions, then I'm starting to think they're moderate going into severe. And then for severe, some of our very clear indicators that a patient has severe respiratory distress is severe retractions again. So the quality of those retractions, intercostal retractions, if they're having head bobbing with every breath that they take, or if they're grunting, and then also nasal flaring is another one that I think about for the kids who are in more severe respiratory distress. In terms of our last component is mental status. And so if it's mild, considered mild, if they're at their baseline, if they're fussy, anxious, or sleepy, then we consider it moderate. And probably of all three of those, I think the one that I see most often when they're starting to kind of progress through the illness and look worse is sleepiness. That always makes me a little bit more worried that we're heading into severe respiratory distress. And then for severe respiratory distress, if they're looking lethargic, so not just sleepy, but they're actually low energy and not really arousing like you would typically expect, a lot of those kids won't be feeding well or just inconsolable. One of the other important aspects of this scale is that if the patient has any of the components that fall into a severe category, then they would count as severe. Same thing for a patient who's less ill, but if any of these three components fall into that moderate category, then they'd be considered moderate. So whatever your highest kind of factor is what you're classified as for this scale.
I feel like this has been really helpful for communication sort of between our clinicians, especially, going from admitting from the emergency department up to the ICU or to the hospital wards, and being able to say this is a child with, mild work of breathing, but moderate tachypnea has been sort of just giving us a common language for how to objectively describe these kids. So part of what we do when the children first arrive in the emergency department is examine them and try to determine what that respiratory assessment classification is. So how severe are they when they present? And then we will try to suction them, because most often they will need that when they come to see us, and then reassessing to see what their post-suction respiratory assessment classification is as well. And so as part of that initial examination, besides just their work of breathing and their tachypnea and their mental status, we also want to be looking at their vital signs for their oxygen saturation, so whether they need supplemental oxygen, and then considering high flow nasal cannula, which we'll talk again about in a few minutes, if they are in severe distress. For all of the kids, we want to assess their hydration status, because it can be difficult for children to feed during bronchiolitis, even if it's just because of the upper respiratory symptoms and trouble sucking, versus some fatigue from the respiratory effort. And so whether or not the child is hydrated enough and can continue to PO if we're suctioning them, or whether they would benefit from nasogastric or IV rehydration as well. And then how often we are reevaluating these kids really depends on how severe they are. And so there is a QR code in that lower right-hand corner that goes to the web page that has our clinical guidelines for UC Davis. And so one of the guidelines there is our bronchiolitis guideline. And so we have some kind of recommendations for reassessments, and it includes every 30 minutes for kids who have severe respiratory distress or severe RAC, and then hourly reevaluations for children who are moderate. If they are mild but still in the hospital for other reasons, most often for hydration, then we can spread out their reevaluations often to every 2 hours. But again, bronchiolitis is a dynamic process, so sometimes they sort of shift between these and do need to be reevaluated more frequently.
We wanted to talk through kind of probably one of the most important treatments that we have for bronchiolitis. Dr. Tzimenatos had mentioned that sometimes we hit a kid with a whole bunch of different treatments that we do have at our disposal, and it's hard to tell, but I would say it's pretty remarkable after you see a kid who gets really suctioned out really well, how dramatic their respiratory distress can improve. And so these are some of the tools that we have both in hospital settings, as well as both hospital and at home. On the left-hand side, we have two different forms of a mushroom tip. On the top is our plastic one, and on the bottom is a glass one. And those work really well. Part of the philosophy behind having the mushroom tip is that we're trying to minimize deep suction and irritation to the nose. And so the mushroom tip on the top is the one that we primarily use, or something similar, in our hospital setting. The next one in the middle, our classic bulb syringe, can be used really effectively. One of the things that I should also mention is that for these to be effective, one of the other most important components is having saline. And so, I'll see sometimes where people will just put in a few drops of saline. I really try to flood the nostril. So you have that surface tension working for you and can get all that mucus out, and it can really help. Next to that, I have an electric nasal aspirator. It used to be that the only electric suction we had was typically in a acute care setting, but now there's a lot more over the counter that some families are also using. And then on the far right-hand side is probably one of the best ones that works most effectively for families, is also kind of no frills, meaning you don't have to rely on electricity and can take it wherever you go. But that's a nose-frida nasal aspirator or similar device. So it has the plastic hub. The suction is created by the caregiver sucking on the tube. And so that one is really effective for a lot of families. I think the other big challenge in terms of doing any of these techniques is being able to have the kid do it. Obviously, for them, it's an unpleasant experience. And so I think especially if you're a single caregiver, getting them bundled or swaddled, even if it's an older kid, so that you can actually effectively get it in their nair and then suction out that saline and that mucus. We put a picture of this just to remind us all that we really try to avoid deep suctioning. As I mentioned, deep suctioning tends not to be necessary for the vast majority of our patients. In addition, the more that we suction and go down into the nasal passage, the more inflammation and edema that we can cause. And so actually kind of contributing to that patient's nasal obstruction. And so we do, again, try to keep things up at the nair.
We wanted to show a little bit more about the clinical guidelines that we have been using here at UC Davis. And so this one is for our emergency department guidelines, and includes that initial assessment that basically we talked about. And then the path that they take depends on their respiratory assessment classification. So how long we watch them in the emergency department, and what supportive elements we offer, as well as how often we reassess them, will really depend on how severe their RAC is. It includes a reminder for initiating high flow nasal cannula. Again, we'll talk about that. And then basically after some period of observation, depending on their severity, we make the decision for admission versus discharge. One element that comes up frequently before we're getting to the point of discharge for our patients, though, is whether or not we need to do further evaluation because of their fever. So again, those AAP guidelines are telling us that we don't need to do labs to evaluate for bronchiolitis, but I think there is still some concern about whether there is infection with something else besides the bronchiolitis, particularly in our youngest infants. So I would say that most of my colleagues and I, after looking at the evidence, We still consider evaluation for urinary tract infection in the vast majority of children who are under 2, with the younger you are, and then other risk factors such as being female or being an uncircumcised male as making us more likely to get that. We know that having a viral respiratory infection attenuates the risk of a UTI, but it does not make it drop to 0. So it's usually about half of what it would be before. So children who have a substantial risk, getting up in that 8 to 9%, as we know many of our highly febrile infants do with risk for UTI, even having bronchiolitis, they will drop down more into that sort of 3 to 4% risk, but still enough that we feel that it's worth screening. And then in terms of doing LP or blood testing in our youngest infants, if they have clear clinical bronchiolitis, they actually fall outside of the guidelines that are have been released from the AAP for febrile infants less than 60 days. And so infants above 60 days or even those under 60 days, if they have clear bronchiolitis, we have learned that routine screening for either bacteremia or meningitis is not recommended. So now thinking about patients that we can discharge home, basically we want their work of breathing to be mild to moderate. We don't want to have any history of apnea and certainly no witnessed apnea. We want to make sure that they're saturating well on room air, both awake and asleep if ideal. So I like to see these infants, if possible, I like to see them feeding, awake, and sleeping to just see that we can make sure that they're maintaining their oxygen saturations throughout that time. And then making sure that their caregivers are able to both suction them as well as bring them back to us or to their caregivers, their primary care for follow-up. So we do some teaching with them before they go, specifically talking about signs of respiratory distress, so how to recognize that. As we had talked about, how and when to suction, providing information on that, and often providing nasal saline so they can administer that with the suctioning. Talking about signs of dehydration, offering frequent feeds, encouraging PO hydration, avoiding over-the-counter medications, and then close follow-up. So this is all part of a set of discharge instructions that we've developed that we give written to the families as well as go over with all of them before they go. And then for kids who are more severe, this is when we talk about admitting them. And then I think whether you're admitting them to your hospital or transferring them to another hospital will obviously depend on what the capabilities and resources that you have available. For us to come to the pediatric ward, our patients are typically in mild or moderate respiratory distress, and then may have some apnea either by history or very mild, but not requiring frequent stimulation or other support. Infants who are hypoxemic obviously need to come in so they can get their supplemental oxygen, as well as infants who can't be managed with anything other than wall suction to clear their secretions. If they need to be if they need to be hydrated with either IV or NG fluids, they'll come in. And then the other one, the last bullet point here, I think is important. So expected progression to meet these criteria. I think we think about the timing of illness for these infants. So if they're, early in their course and they're already developing sort of mild symptoms that seem like they have the potential to progress to moderate, and they are in any of those high risk groups, especially, a history of prematurity, that young age or underlying conditions, I think we're more likely to admit them so we can observe and then offer supportive care if they worsen clinically. For our ICU admissions, we are reserving that for children who are having severe respiratory distress despite being placed on high flow nasal cannula, or if we anticipate the need for CPAP or other non-invasive or invasive positive pressure ventilation. For our infants with higher FiO2 needs, we often want them in our ICU so they can be closer monitored for risk of dehydration. If their mental status isn't improving, if they're having prolonged apneas, or if they're requiring more intensive suctioning or nursing care, those patients will go to our ICU as well. So I think these are some considerations that you can have for whether a patient would be appropriate for transfer to a higher level of care as well.
So I briefly wanted to just comment for our patients that come in the hospital. As Leah had mentioned, we do have that QR code throughout some of the slides that can give you access to these to review and see kind of how it may apply in your setting. But some of the things that I wanted to emphasize in terms of thinking about ward admission and some of the issues that we've had to adjust and that come up. The O2 SAT parameters that we use, we want their SATs to be 88% or above when they're sleeping and 90% or above when they're awake. For us, when I first started practicing here, that was a big adjustment. I think being closer to sea level, we're not used to seeing kids be hypoxic or on the lower side of the scale. Having come from altitude where people hang out closer to 90, I was really familiar with that. And so I think it's been really important for us to shift in terms of when we're intervening and what we're accepting in terms of acceptable SATs to that lower threshold so that we're not unnecessarily keeping kids in the hospital and giving them an intervention that they don't need. Having said that, obviously it's a whole picture in terms of whether they have hypoxia, as well as what their work of breathing is and what we're seeing in addition to that. One of the other things that we also have been really focusing on in the inpatient setting is adjusting how we're monitoring these patients so that patients who are not requiring oxygen, we're working to get them off continuous pulse oximetry, and that kids who are stable, again, we're trying to transition them off continuous pulse oximetry. And you'll see that kind of in the bottom of these plans in terms of mild and moderate. So that we can work towards getting them to a home setting. For a lot of families, it can be a challenge and discomfort going from being monitored all the time to that. And so that kind of also prevents us from doing unnecessary interventions for a mild DSAP that self-resolves, and then also helps the family transition to that mentality for home. Other notes, our discharge criteria mimics the criteria that Dr. Tzimenatos went over. For kids who are in that severe category, we do initiate high flow nasal cannula on the floor. And so we'll think about it for patients who are in that moderate category, but for severe, we'll go ahead and initiate that support. One of the other things we wanted to mention, we've touched on it before, but tobacco smoke exposure does increase the risk of bronchiolitis. It increases the odds ratio to 2.51 in terms of those patients requiring acute care. And then in terms of admission to the ICU, if they have prenatal exposure, the odds ratio is 1.51. And if they have postnatal exposure, it's 1.95. So almost twice as likely as a child who doesn't have postnatal exposure of ending up in the ICU. And so I always use bronchiolitis as an opportunity to evaluate whether the patient has tobacco smoke exposure and intervene. So in terms of addressing tobacco smoke exposure, we ask about it, we identify the source. Sometimes it may not be a parent, it may be another caregiver. There's lots of free smoking cessation services. We have on the right-hand side our California Smokers Helpline. And then we also talk about ways to minimize smoke exposure. The other thing that I say, I think as a provider, sometimes we can get caught up in being frustrated with people who don't quit, but we just have to remember that it takes an average of 8 quit attempts to be successful in quitting. So checking in with people and encouraging them.
We had touched a little bit on high flow nasal cannula and just wanted to go back to it to talk about this modality, because I do feel like over the past years, this has been something that's been successful in helping us to support these infants as we're sort of standing there and not doing as much as we would like to be doing. So for this, we are referring to the warmed, humidified oxygen that's administered typically at higher rates. So for infants, we tend to give it at 4 to 25 liters per minute. We know it can certainly go higher than that as well. And there has been good evidence that it is safe and well tolerated in infants with bronchiolitis. It has shown some improvement, certainly in their oxygen saturation, but also in the need for escalation to intubation or other respiratory support. When you look at some of the studies, it actually, when you include all comers with bronchiolitis or all comers with hypoxemia and bronchiolitis, it is not routinely helpful across the board. So we've been trying to sort of isolate the population that we think will benefit from it the most, and how we can use it. So this QR code shows again, takes you to that website for our clinical guidelines, and there's another one that we have specifically for high flow nasal cannula. And our general recommendations here are that we initiate it for a severe respiratory assessment classification, but then we also consider it for moderate, depending on what their combination of symptoms are. We also consider it for children who are requiring at least 2 liters per minute of standard nasal cannula at 100% FiO2. The idea being that we can probably make them more comfortable, and then we can also titrate their FiO2 if we switch them over to high flow nasal cannula. And then there are some exclusion criteria from our protocol. This isn't to say that these kids don't benefit from high flow, but they can't be managed necessarily in that same standardized way that our typical children with bronchiolitis can. So those are kids that are outside of the 3-year age range who have a primary diagnosis other than a viral lower respiratory infection. If they have significant apnea or bradycardia, and then specific comorbid conditions. And again, for our kids with neuromuscular disease or chronic lung disease, it's not to say that the high flow won't help, but we need to sort of consider them as a different group. And then from my point of view in the emergency department, one of the most helpful things about the protocol has been standardizing our initial approach. So our initiation flow rates are listed here. And basically for infants who are moderate to severe, we're initiating most of those at 2 liters per kilo per minute if they're less than 10 kilograms. And then we max at 20 liters per minute. So everyone who's over 10 kilograms gets 20 liters per minute. We also typically start their FiO2 at 50%, but then we titrate it, again, not aiming for perfection, knowing that these are this is a time when children are going to be more hypoxic, and it's not dangerous for them to be at these lower 90s or even 88% while asleep. So trying to titrate their FiO2 so that we're maintaining those saturations. We can adjust those as needed, but I think, again, it's been helpful for us to have sort of a standard initial approach. The other piece of the guideline that's been very helpful for us is what is listed here as the nutrition guidelines. So there had been, I think, confusion when high flow was earlier in its course about whether children who are placed on high flow are safe to take PO feeds. And so I think that led to many infants getting IV fluids or NG fluids when they probably were safely able to PO. And now that I think we've been watching them for longer, we've been able to sort of better delineate which kids those are. So basically kids who don't have severe tachypnea for age, whose respiratory assessment classification is either mild or moderate, and who are on not our maximal flow, are definitely kids that we consider oral feeds if they're willing to. If they're having concerns for aspiration specifically, or if they're having persistently severe racks, then we do consider alternative hydration for those kids. And then thinking about nasoduodenal feeds if they are having vomiting or they're not tolerating NG feeds are also possibilities as well.
This is our overall algorithm in terms of kids who are on high flow on the floor. And I think there's 2 things that I wanted to comment on in the orange boxes, thinking about kids who are worsening. So for our patient population who's on the high flow per protocol, the levels that Leah had mentioned, for those patients who are doing worse, we typically will escalate them to the PICU. And most often those patients get placed on CPAP. So we're looking for those symptoms of worsening. I think the other big thing is that in terms of getting kids off of high flow, we do frequent trials, taking them down on the high flow to 1 to 2 liters. If they tolerate that, then we transition them to a regular nasal cannula. And so having the frequency of those trials occur has been important in terms of progressing kids through the pathway, and instead of just kind of letting a kid continue to cruise and not reassessing whether they still need the high flow nasal cannula. A lot of these patients, as they improve, kind of hit this point where they're just better and doing much better, as opposed to a more gradual progression. And so that's been really effective in terms of our length of stay. So in summary, less is more in the treatment of bronchiolitis. We admit these patients for supportive care if there's concerns about respiratory effort, oxygenation, hydration, or apnea. We use high flow nasal cannula in children with moderate to severe respiratory distress. And we're offering RSV vaccination to birthing parents and immunoprophylaxis to infants. We're going to scroll through these slides that are different references. In addition to that, we also will ask people to go ahead and take this very brief survey. It helps us to have feedback in terms of how effectively We're sharing this information as well as letting us know if there's other interest or topics that you guys would suggest that we cover. We would really appreciate that feedback.